we'll be able to learn about it. Thank you. So we've started the recording. Next slide, please. So I am Carmen Masson. I am a professor of psychiatry in the School of Medicine at the University of California, San Francisco. And I co-lead the I-STARR project with Amy Miracle, who is a research scientist in the alcohol research group at the Public Health Institute. The team also includes co-investigators Sarah Zemore and Lenny Jason, and biostatisticians Mina Subbaraman and Libo Lee, and communications specialist Diane Schmidt and Dustin Ketsu. Our project coordinator is Quinoja Capitini. Next slide, please. So the I-STARR activities are also guided by a 17-member advisory board comprised of a diverse group of leaders from across the country. And most of the members wear many hats, but also they represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, as well as researchers and educators. Next slide, please. So now, we'll skip this slide and skip that. Okay, so now, without further ado, I would like to introduce Jason Howell. Jason is a person in long-term recovery from mental health and substance use issues. He has an MBA from Texas A&M University and is a recovery support specialist and supervisor. Jason is the executive director of Recovery People, a nonprofit that engages, educates, and empowers change makers to use their lived experience to help others affected by substance use and related mental health challenges. He is the founder and the former board president of the National Alliance for Recovery Residences, or NAR. He's also a national speaker and has co-authored several peer-reviewed journal articles. And with that introduction, I'm pleased to hand things off to Jason, who will provide an overview of medication diversion risk management. Thank you, Jason.
Oh, thank you so much, Carmen. Next slide. And before I start, it's exciting to see somebody in the room from Afghanistan. That's awesome that we've got such a great draw. Yeah, and I also want to thank I-STARR for inviting me back to talk about this topic. Medication diverse risk management is definitely something that we should talk about. I'm thinking back several years now when we started seeing the opiate epidemic here in the United States, and there was a lot of pressure for recovery homes to start accepting persons on medication-assisted treatment, or MOUD. And I remember attending a webinar where the speaker, their strategy was to minimize diversion risk as a way of convincing recovery housing providers that they should start accepting people on different medications. I really didn't find that helpful. They may have believed that, and we're really trying to impassionately, get people connected with recovery housing. But my approach today is to acknowledge that, of course, diversion is a risk. We should acknowledge that and then look at ways of reducing the risk around that. And with that, would you go to the next slide, please? So what is diversion? That's the first section we're going to focus in on. What do we mean by diversion? Next slide. So this definition here is being provided by the CMS. Drug diversion is the illegal distribution or abuse of prescription drugs, or their use for purposes that are not intended by the prescriber. Prescription drug diversion may occur at any time along the distribution channel. So from the manufacturer to the wholesaler to the pharmacies, all the way to the patient. And so we should really kind of think about, where diversion could be happening. Next slide. who might divert medications. And my position is really anybody who has access to a prescription has the potential for diverting it. And when you Google, diversion, most of what's been written really focuses in on the medical profession, whether it be in the ER or in private practices, even pharmacies. And so that's where that first bullet point comes from. Medical professionals may be involved in diverting prescription drugs for recreational purposes, for relief of addictions, monetary gain, self-medication for pain or sleep, or to alleviate withdrawal symptoms. And I've added the next bullet point that says, like medical professionals, individuals in and around recovery housing could potentially divert medications. So when we're developing our policies and procedures, when we're developing our diversion risk management, we need to acknowledge that there's lots of different players who have the potential, including owner operators, as well as staff, residents, as well as visitors that come to the home. Next slide, please. So, looking at what drug classes have the highest potential for drug diversion and or abuse, these have been highlighted by the National Institute on Drug Abuse, as well as the U.S. Drug Enforcement Administration, anabolic steroids, central nervous system depressants, hallucinogens, opiates, and stimulants. So there's quite a few drug classes that are known for having high diversion potential. Next slide, please. So the most common types of drug diversion, like how does diversion happen? And again, this is from Health and Human Services or CMS. They've identified that, selling the prescription drugs, excuse me, doctor shopping, and that can be interpreted as, having multiple doctors or or finding a doctor that's going to prescribe you a particular medication or a higher dose of a particular medication. Illegal internet pharmacies, and I won't call out any particular social media channel, but as I go on social media, sometimes I think that these internet pharmacies are targeting me because I see so many advertisements, and some of them are not legit, meaning that they are illegal internet pharmacies. Of course, drug theft, not only drug theft, but theft of prescription pads and then forgery of prescriptions along with that, and then illegal prescribing. So this is typically what is thought of as the common types of drug diversion. And if we go to the next slide, this is the type of diversion that I oftentimes hear in recovery housing. And so when you go to the NAR conference or meet with other recovery housing providers, trying to figure out what are they typically seeing. This is what I hear. Individuals that come from an addictive lifestyle may be very accustomed to trading medications, sharing medications, selling medications, of course, stealing medications, even self-medicating. So taking more or less of a medication, combining medications with other substances can all be part of addictive behavior. Also, doctor shopping, which is similar to the previous slide. Having duplicate scripts, so maybe going to multiple doctors, and as policies have advanced, we're seeing less and less of that, but it's still a possibility of having duplicate prescriptions. And then malingering, and that might be a new word for some folks. So if we go to the next slide, I'll unpack what I mean by malingering. So malingering, it's the falsification or a really profound exaggeration of symptoms to get external benefits. Again, this can be common in drug seeking. So if I were to go to a prescriber and talk about certain symptoms that I may not have, but really kind of exaggerate that I have certain symptoms that all would lead a prescriber to write a particular medication. This has been documented in a lot of different drug classes, and the bullet point there is when elevated from an ADHD medication or stimulant example amongst college students. But this, of course, this can happen with any medication. Next slide, please. All right, so now we know what diversion is. Let's start moving into the risk management around that. Next slide. And I want to highlight that risk management, there's really three phases of it, or I think of it as three phases. There's the before the crisis. We should think about prevention, preparedness, and readiness. But that's not only it. We need to think about, the crisis and developing policies and procedures and really prepare our staff to be able to respond to a crisis, in this case, diversion, as opposed to reacting to it. And, it's, if you don't practice or think through it, you definitely can get in those moments and start reacting than responding. So a big part of risk management is preparing for the crisis. And then, of course, after a crisis occurs, recentering yourself, recentering the recovery home, recording and reporting as appropriate. Also spending time to reflect on how did the policies and procedures that we had in place perform? How did it manage the risk? Is there an opportunity for improvement? And then implementing those improvements, and then you start the cycle over. But what I want to spend most of our time today talking about is that preparedness, that before the crisis phase. Next slide. When I first came to recovery housing, my gosh, this was back in 2009, and decided that that's what I wanted to do, was open up recovery homes. You talk to the recovery housing community, and there's three words that come up over and over again: structure, accountability, and culture. And so some of what I'm going to be talking about today is how to leverage those natural resources, the natural framework within recovery housing, as tools to support diversion risk management. And then I've added a fourth called relationships, because I think there's a huge opportunity and room for growth working with healthcare professionals around this. All right, with that, let's spend some time talking about each one of these areas. Next slide. Structure, a great tool in our toolbox. And when I say structured and recovery housing, what I'm talking about is the policies, the procedures, and then these tangible resources that we can use to support diversion risk management. Policies, those are the rules. Those can be the house rules, really the rules for staff, and being very explicit in the rules around diversion, forbidding diversion, having a rule requiring reporting. There's a saying, you see it, you say it. It's important to report diversion. And when we talk about the recovery culture here in a little bit, one of the things about recovery housing is you want to create an environment where it's not an us versus them, residents versus staff. It's an us responsibility around things. And you can start framing that culture with your structure. Disclosing medications and having residents disclose their medication is not to exclude them. I mean, what we're talking about is, bringing individuals into recovery housing that are on different medications. But it is important to document what medications they're on, because as you see in the next slide, we're going to be talking about UAs and those, when you do a urinalysis of someone, what shows up in their UA results should reflect what they've reported, that the medications that they're taking. But you have to have a rule around that. Rules around providing releases of information. Rules around securing medications. I can remember years ago when you would walk through a recovery home, and part of the way that you could tell whose bed was who is what prescription bottles were sitting next to it. That's clearly not best practices. We need to make sure that everyone understands that securing medications is part of safety and is reflective of recovery. Um, Rules around talking to prescribers before a resident changes or discontinues their medication. I don't know if Ralph Fabrizio is on today. Ralph runs recovery homes in the Houston area. House of Extra Measures is the name of the organization. And he and I talked at length about this, and it was a real game changer for him and for his houses. If individuals are starting and stopping and changing their medication without talking to their prescriber first, it really can destabilize them and in turn the household. So definitely this is a policy or a rule that you should consider. Moving from the policies, let's talk about procedures. Procedures are how we do things and really spelling out how we do things in this particular recovery home. You should have standard operating procedures or SOPs around disclosing, storing, controlling, taking, changing, logging, auditing medications, making sure that you take the time to really unpack all that and spell it out in a policy and procedure. Procedures around UA screening, whether that means somebody moving in for cause on a particular schedule, as well as when to use point of care versus confirmation labs. And we'll talk about that in the next slide. What do we do? What is the procedure when we have a diversion concern? That should be really thought out and written down. As far as, what is our process for communicating with prescribers or other caregivers or other supporters for this particular resident? And then in the third column, we have resources. These are those tangible resources. You may be thinking of the personal lock boxes, medication lock boxes. I've seen some of those that attach to the foot of the bed. That would be a great example. The next two, I've got an asterisk put next to it. These are centralized storage lockers and centralized safes. Anytime that you as a recovery home or staff starts taking medication and locking it away from the residents, creating additional security around that, it's going to increase your liability. And we're going to spend a couple slides from now talking about liability and why you should really think through whether that's a strategy that you want to use or not. Other resources, a medication log or a medication log template for people to record their medications. One that I use and really has improved my compliance around medication is a pill organizer or a pill box. And we've also seen technological advances. There are pill dispensers that have a kind of a time clock on it, and a particular pill box lid doesn't open until it's that particular day to take the medication. So more things to come on that. Next slide. Accountability. When I say accountability in a recovery home, I'm talking about UAs, audits, as well as observations. And I've already started speaking a little bit about this. When you do a UA on an individual, the results should reflect the medications that the resident has disclosed. And when we think about what type of tools to use, the less expensive as well as less accurate screening tool is a point of care cup. There are breathalyzers, there's other preliminary screening devices, but the one that we see most often is a point of care cup, especially because you can get panels nowadays that test for specific medications. Note, these are less accurate. So make sure that you're not making any life-changing decisions based on the result of a point of care cup. Let's say, for instance, you got a result back that was not what you expected. That would be the appropriate time that you would consider a more expensive test like a lab confirmation test. Moving to the next column, we've got the audits and requiring residents to maintain a log that inventories the medications and the type of medications that they receive in, as well as the amounts that they are self-administering. This would allow them to periodically conduct a self-audit and compare, how many pills do I have versus how many pills should I have, and do that self-audit. Um, this is also a very helpful time or a helpful mechanism for them to be thinking about their refills. We don't want to run out of medication and have somebody go through withdrawals. So this law can also help them think through, when should they call for their refills? Oftentimes we have individuals that may have started medication in a treatment center or somewhere else, and then they move to your recovery home. They may need to find a new prescriber, and that may take time. So really having this all mapped out on paper can be really helpful. That brings me to the last column around observations. Peer accountability in recovery housing is something that we talk about a lot and encourage. You know, having individuals, observe and report changes in behavior can be really important. I know about me in early recovery, I didn't have the amount of self-awareness that I could have or should have. And so in recovery housing, we encourage roommates or housemates to really kind of report changes in behavior that could have somebody remember, oh, I didn't take my medication, or I changed my medication, and this is the type of behavior change that it's causing. It's really important not to jump to conclusions. If you do see someone that has a behavior change, you shouldn't automatically assume it's because they've diverted medication. So really use this as a way to bring self-awareness to an individual. But of course, if there is a diversion concern, well, that's the time that you would take it to the house manager or whatever staff has been designated. Let's see. And we're going to talk about observing self-administration of medication on a different slide. So let's go ahead and advance the slide. That brings us to culture. And this was when I started recovery housing. This is what my mentors stressed over and over again. The culture of a home is really the heart of the home. From a diversion risk management perspective, we should think about awareness and educating and re-educating residents on what we mean by diversion and diversion risk and the consequences of diversion, not only the consequences to the individual, but the potential consequences to the household. Promote peer awareness and peer accountability that we've talked about, and it's not something that's punitive. This is about creating a safe environment and creating a recovery supportive environment, and that diversion risk management is reflective of recovery. That brings me to the next column around beliefs. And if you're a recovery home that is accepting persons on medications, making sure that you've established a culture of recovery using a definition of recovery that is inclusive of taking medication. When I talk to individuals who are on medications, living in a recovery home, they have expressed so much gratitude that they don't feel stigmatized, that there are other people in the home that are on medication. It's not that they're comparing medications, but they are able to support each other's choice to be on medication as a means of supporting their recovery. We should also instill the cultural belief that we are not doctors, we are not pharmacists, that decisions about medication should be between individuals and the healthcare professional. That goes for staff as well as residents. If you catch residents that are making recommendations around dosing and what medication people should be on, it's an opportunity to redirect. That is not our cultural belief here. And kind of reinforcing, part of being in recovery and being responsible around medications in recovery is talking to your doctor or your prescriber before you decide to stop the medication or change the dosage. And then the final thing around culture I want to talk about is rituals. Medication sometimes can seem tedious or maybe heavy, and it doesn't have to be that way. When you are creating these policies and procedures, when you are thinking about, when individuals are self-administering their medication, you can create a recovery ritual around that. Maybe it's, a time for meditation. Maybe it's a time to really check in with a resident to see how they're doing, and introduce a recovery coach or a peer specialist at that time. There's just so many different ways that you can turn, taking medication into a positive and something that is very recovery supportive. Next slide, please. Relationships. So this is the one that we have probably the most opportunity, the most work to do. I think historically, recovery housing has not been seen as part of the larger healthcare continuum. I think that, as we start moving into value-based payments and we start looking at recovery housing being part of a bigger system, that there'll be more opportunities for recovery housing providers to talk to healthcare providers. But historically, we've not seen that. And I'm going to spend more time next month. I've been invited next month to talk about, I think the title of it is Prescriber, Friend, or Foe, to do a deeper dive in this. And so if this interests you, come back next month and we'll talk more about it. But what I'll leave with you today is that, when we're developing these relationships, it needs to be developed on respect and trust, as well as making sure that the legal documentation is put in place, and so that you can have these conversations with prescribers. All right, next slide. All right, we're getting to the third section of the presentation, and this is about staffing, legal, and liability limits. Next slide. So I think we need to be real honest. Different recovery housing have different capacity to implement different types of diversion risk management strategies. So the graph you see here, it kind of shows that there's the different types of recovery homes. The National Alliance for Recovery Residences, or NAR, describes it or has a framework called the levels of support, levels 1 through 4. And really here you see that level 1s and level 2s, they don't have the staffing capacity to implement certain things like level 3s and 4s. A level 1, the best example is an Oxford House. There is no staff. This is democratically run. There's elected house officers, but there's no staff in the typical way that we think of staff. Now, level 2s, an example of that is going to be your sober livings. There is an individual that's designated as the house leader, the senior resident. Sometimes they're called the house manager, but that individual likely has a day job. They're not there at the home all the time. They're really acting as the liaison between the community in the home and the owner operator. So expecting a level 1 or level 2, someone in those homes to always be around on site and giving people access to medication, it's just not, it's not feasible. If we want to use more of those sophisticated or complex strategies around diversion risk management, we really need to think about 3s and 4s. All right, next slide, please. Liability limits. So one of the things that I've noticed is that recovery housing oftentimes get pressured, and I'm calling these patriarchal perspectives or external pressures from the healthcare industry or parents that don't really understand recovery housing, especially level 1s and 2s, for the recovery house to take on more responsibility, such as controlling medications. We talked about that most recovery homes don't have the capacity, but even if they did and you take on that, it's increasing your liability. And I'm not an attorney, I'm not an insurance professional, but you really should be talking to those subject matter experts in developing your risk management plan. Definitely make sure that you have the right insurance in place, as well as kind of navigating the legal issues around your particular risk management plan. Next slide. Okay, the legal limits around dispensing and administering medications. And these words are used loosely sometimes. And I think there's some danger in that. And we need to be very specific about when we use words and what we're talking about, because it has some legal ramifications. And know that the laws around this differ from state to state. So it's important for you to know your state law as well as keep abreast of it, because of course, state laws can change. But in general, when we say dispensing medication, that's describing the selection or labeling of prepackaged medications ordered by a prescriber for an individual to self-administer. Individuals who can dispense medications, that's going to be your pharmacists, physicians, registered nurses, not recovery housing. There's another term called administering medications, and this is giving a client a single dose of prescription medication. All personnel who are licensed to do so can administer medications. That is, I can't even imagine a situation where that would be a recovery home. But this is sometimes where recovery homes may think that they should overstep, or they get pressured to overstep and actually administer the medication. Please know that you're likely not, turn to your state law, but you're likely going to be stepping across a legal line if you're doing that. Now, self-administration, that's an individual giving oneself or taking their medication. And that leads me to the third column, which is observing self-administration. This is more likely to fall within what recovery housing can do. It's observing an individual giving themselves medication. And what I will leave you with today is, without legal authority, recovery housing staff should not touch anyone else's medication but their own. And with that, I think we can advance to the next slide, and I will pass it back to you, Carmen.
I am here. Thank you so much. That was just an excellent presentation. And we have a number of resources for you. I know it's a lot of information to cover in the webinar. Next slide, please. So this is some information where you can learn more. It contains resources and additional training about topics covered today. And we've tried to paste many of these resources into the chat along the way. And we'll also continue to paste some of these resources when we have our question and answer session. Next slide, please. So given that we have what we've reviewed on managing medication diversion risk, I'm eager to open things up to ask, to ask you if you have any questions for our presenter on this topic. And if you have any questions, our host is monitoring the chat. I don't think, Diane or Dustin, that you can see somebody's hand raised, right? Oh, you can.
I actually can see, yeah.
Oh, great. Okay, so you can actually raise your virtual hand or put a question in the chat for Jason. So now is the time to ask any questions you may have. Thank you.
Yeah, so thanks, Carmen. So Jason, we have a quick question from Christine. Christine, do you want to unmute yourself? And
Sure.
You can even turn on your video, I think, if you want.
Can I turn? Oh, no, I don't have an option to turn my video on. I'm sorry.
Okay. That's okay. We can hear you.
Jason, if we run, it's a weird thing in Oklahoma. We're kind of a cross between a recovery residence and a treatment facility. We are level 3 OCAR NAR, level 3 certified, akin to a 3.1 ASAM level facility. We keep all of our resident medications in a locked room, and when they come each day to get their meds, we hand them this box. It slides in. We take their box out. We hand them the box. They take what they need. We take the box back and put it in. Does that cross the line of the observing self-administration that we're, quote, handling the medications? They put the medications in the box. We put the box in the storage unit. We hand that box out, but we're not handling individual medications per se.
I'm not an attorney. I'm not an insurance professional. I'm not an expert in Oklahoma law. now that's out of
Yes,
the
that
way.
disclaimer.
I think that's how I see a lot of recovery housing providers do it if they choose to secure medications in a centralized area. The way you describe it, it doesn't sound to me like staff is touching the medication, dispensing it. You're just giving, a resident access by handing over their box.
Correct.
I've heard several recovery housing providers doing that if they choose to centralize. The other way to do it is that everybody has their own lockbox there by their bed. But of course it's not as tight as controlled as what y'all are doing. Hopefully
Thank
that
you.
helps.
Thanks, Jason, and thanks, Christine, for the great question. Anybody else have any questions? This is a great time to ask an expert. Oh, we have a question from Catherine. Catherine, do you want to unmute yourself, please?
Yes, thank you. So this is scaring me because we're a level 2 facility, and I know we've been in business 20 years, so kind of maybe some antiquated ways of doing things. We store all their medications in a locked room, and then once a week they make their own med packs, but we audit the meds after and we count each pill. I feel like that might be putting us in a dangerous area. I'm aware of the disclaimer, but I'm wondering if I need to revamp my policies.
Yeah, and just thanks for the former disclaimer applies here. It sounds like y'all are actually auditing and touching the medication. Man, if that were me, I wouldn't do that. Now, you can observe the resident auditing their medication. And I think that that's how I personally would do it. I mean, one, it's giving the individual self-agency. It is empowering them. You're supporting them and doing their own audit. And you can wrap that in the culture of this is what people in recovery do. That would also, I think, limit your liability. Anytime that you have staff, touching and auditing the medication, what if some medication went missing? The resident could say, well, you stole it. I don't know. I think you would be wise to kind of reflect on how you're currently doing it and seeing if there's any room for improvement.
Awesome. Thank you so much. I appreciate that.
Okay, thanks, Jason. We have another question in the chat from Roland. Was the discussion about regulations inclusive of the DEA?
So there's a couple of different regulations going on here, Roland. So the DEA, if I remember right, so they control what medications are scheduled, like what drugs are controlled and not controlled. Of course, a lot of the medications that we're talking about that have diversion risk are controlled substances. But if you're asking the question about, who is able to dispense, administer versus observe self-administration, my understanding is that is determined at the state level. And so you would need to look at your state laws. And for lots of different reasons, state laws regulate who can dispense and administer medication. And that's any medication, just not controlled substances. But of course, we're most concerned about diversion of controlled substances.
Hey, thanks, Jason. I don't see any other questions in the chat. So one last call for questions if you have any. Otherwise, we will move on from the Q&A.
I did see something about having copies of the slides.
Mm.
I'm comfortable with it, but I also know that this is being recorded and being posted on the website. Either way, I defer to I-STARR and how they want to distribute this.
Okay, thanks so much, Jason. Yeah, and I'll hand it back to you, Carmen.
Thank you. Thank you for all your questions. Really, really important. So before we leave, I want to tell you a little bit about some relevant activities that are coming up in the next couple of months. Next slide, please. So we will be hosting another webinar later this month, one that is specifically geared towards researchers. And the research webinar will focus on strengthening causal inference. And then later in March, there are two other presentations or webinars that we'll be hosting. One is for operators and providers, that webinar. That for that webinar, we'll also have Jason Howell coming back and talking on the topic of the medication prescriber. And the research webinar will focus on multi-level modeling. And finally, I want to bring to your attention that that there will be an important conference. It will be the first national conference on addiction science, or it's also named NCARS. And this is a 2-day virtual conference that's being organized by the 4Rs Network. And it's the first national conference specifically dedicated to addiction recovery science. And it's going to occur on April 24th and 25th. And right now registration is open. And for those who register early by March 7th, you get a discounted rate. And we will drop a link into the chat where you can learn more about that conference. I also want to tell you about the opportunity to participate in some groundbreaking research on recovery housing. And in addition to trainings and the webinars that we provide, our project also supports research infrastructure by funding pilot studies. And one of the pilot studies that we funded is led by Rachel Winograd at the University of Missouri, St. Louis. And she'll be pilot testing a measure of barriers to medications for the treatment of opioid use disorder and recovery housing that assesses stigma and capacity from the perspective of both operators and residents. So now I'm going to hand off the mic to one of Dr. Winograd's team members, Rashmi, who will tell you more about this opportunity. Rashmi, take it away.
So hi, my name is Rashmi. I work with Dr. Winograd, and as previously mentioned, we have started collecting data for this pilot study that the I-STARR grant is so graciously funding. I'm not sure if you have all of my slides, do you? Yes. No?
Yes.
Okay, great. Could you head to the next slide then? Okay, so the goal of the project is to pilot and create a measure to specifically examine attitudinal and capacity barriers for MAT in recovery housing settings, specifically for two audiences, recovery housing operators and recovery housing residents. We're really trying to get a very nuanced picture of what are some of the barriers and issues behind supporting MAT in these specific settings. Next slide. So far, we've had the opportunity to work with a number of subject matter experts, both in Missouri and on a national scale. And from their input, we were able to grab some themes and ideas and sort of refine them into survey items to really hone into what some of these barriers might be. Next slide. So right now our survey is live. We have somewhere between 50 to 60 participants at the moment. Our overall goal is to get 750 people total, 250 operators and 500 residents across the United States. For this explicit purpose, each operator can only do the survey for one recovery house. So for example, if one individual is the operator for several recovery houses, they would only be allowed to do it for one of those recovery houses. Whereas up to 10 residents per house can participate in the study. Every participant will be receiving a $15 Amazon e-gift card sent by me. So I guess if you have any problems with that, email me. And they will receive that typically within a week. The surveys take between 10 to 20 minutes for both operators and residents. Next slide. So this is a little bit scary to look at, but basically our process flow is to have the operators take an eligibility screener and then redirected to the Mo I-STARR survey. And after the operators have finished their Mo I-STARR survey, they will be contacted via email to receive a unique survey link for their recovery house that up to 10 of their residents can take. Basically, we want to kind of avoid bots and some other like fraud detection stuff. So we're hoping by sending each operator for each recovery house a unique link, we're able to bypass some of those issues. And from there, the operator will be able to distribute the link to any of their residents, all of their residents, and residents will be able to complete the I-STARR survey themselves. So since we do have someone approving on the back end that, you're not a bot as you fill out the survey, typically operators can expect to receive the email with survey links within 24 hours, but not necessarily within 10 minutes. Next slide. So as mentioned previously, we have launched the study and it has been really, really interesting so far. We've gotten between 50 to 60 participants at the moment, but like I said earlier, we're aiming up in the several hundreds. So the more folks to fill this out, the better. The link to our eligibility screener is on the slide, and I did also drop it in the chat. So if anyone on this call is a recovery house operator, feel free to copy and paste that link into your web browser and go ahead and fill out our screener. And if you have any contacts in the recovery housing system, specifically operators, please feel free to share any of our information with them. And if you have any questions, please feel free to email mo@istarr.umsl.edu. And I see Rachel Doherty said that the recovery house was able to do the study, and thank you for the endorsement. We tried really hard to make this as least burdensome on our participants as possible. So hopefully that came through in the actual study and survey. And last slide. So yeah, please help us spread word about this study. Like I said previously, we are available at mo@istarr.umsl.edu if you have any questions. I'm in the process of creating a poster that recovery housing operators can send to their networks. So if you have any interest in receiving that poster, feel free to drop your email in the chat and I will send it to you as soon as we have that ready. Thank you so much for your time.
Thank you, Rashmi, for sharing information about how folks can get involved in this really important study. Okay, so finally, before everyone signs off, I want to directly speak to those who have registered for the 12 webinar provider training series or those who are considering registering for it. It's important for you to know that the webinar counts towards the 12 trainings. Actually, you can obtain a certificate of completion and also the option of being identified on the I-STARR website. And you can also earn a NADAC CEU. Now, it's important for you to know we also track attendance for all those who attended the webinars live. But if you have to miss any of the webinars, we have built a platform onto our webpage for folks to view the webinars there. And I'm going to pass things off to Dustin Kedso to tell you a little bit about what this is and what it can do for you. Thank you.
Thanks, Carmen. Hi, everyone. So we're really excited to finally launch our new I-STARR training series. We created a 12-lesson online course that coincides with the webinars and offers opportunity, as Carmen mentioned, to earn continuing education credits. Anyone that's interested can enroll as a student in one of our 2 training tracks, either as a researcher or an operator and provider. Each of the webinars are broken down into a lesson that utilizes supplementary material links, interactive video components, and knowledge checks. If you're interested in enrolling in the training series, you can follow the link, which is at the bottom of this slide, which we're also going to drop into the chat. So once you get to the page, you can select between one of the 2 tracks, as you can see on the slide, and then click on the Take Course button on the top of the screen to register. You'll then have the option, and then you will have the ability to access all the webinars that have been conducted so far. Please send us an email at I-STARR.ARG if you have any questions. With that, I'm going to turn it back over to Carmen to close out today's presentation. Thank you, everyone, so much.
Well, thank you, Dustin, and thank you, everyone. It's just been a delight sharing all this information with you, and we hope to see you back here again for a webinar down the road. Again, don't forget, Tuesday, March 5th is our next provider webinar. And please feel free to contact us if you have any questions in the meantime or interested in learning more about the I-STARR project or activities. Thank you again. Hope to see you soon. Bye-bye.